Ever since Patricia started taking EpiJoint, which has that new ingredient Epitalis in it for mild arthritis, she's got a whole new lease on life. Even discovered a passion for blacksmithery. She makes horseshoes, medieval armour, oh, and her favourite, the mace collection. She's out the back making a ceremonial claymore right now. Yep. She's never been happier.
Well, Musculoskeletal Health Awareness Month is well and truly heading towards its climactic finale, with the world's biggest sit-in coming this Sunday, the 26th of October, and of course the Coadlo lecture next Tuesday on the 28th of October at 7 p.m. More on both of these events a little later. Good evening and thank you for joining us for tonight's final special MAM webinar for 2025, the link between arthritis and heart disease. My name is Helen Gents and I am a member here at MH of the team here at MHA. I would like to take this opportunity to acknowledge the traditional owners of all the lands from which we are joining the webinar this evening. On behalf of Musculoskeletal Health Australia, I pay my respects to the traditional owners and custodians of these lands and acknowledge and uphold the traditional owners' continuing relationship to the land and waterways. Before we get started this evening, some housekeeping. We will have the chat feature open throughout the webinar, which is being monitored. Please feel free to put any questions or comments in the chat and we will endeavour to discuss them during the Q&A part of this session. Also, if this evening's webinar raises any questions or concerns, please make sure you call the Musculoskeletal Health Australia Back Pain, Arthritis and Musculoskeletal Conditions Helpline, or as we like to call it, BAM, on 1800 263 265 and speak with one of our highly qualified healthcare professionals. Now, on to tonight's incredible topic and presenter. It's not uncommon when arthritis and other musculoskeletal diseases are discussed that many think they're not that serious, or they're just part of getting older and we'll all get it one day. The truth is, conditions like back pain, arthritis and osteoporosis are incredibly serious and have lifelong impacts on people's overall health and well-being that can be incredibly debilitating and in some cases life-threatening. That is why tonight's topic is so important. We need to recognise and understand the critically important role musculoskeletal health plays in our overall health and well-being, and how musculoskeletal disease, like arthritis, can be linked to other serious comorbidities such as heart disease. We couldn't have a more incredible presenter and expert to take us through this important topic this evening. Dr. Monira Hussain is her principal research interests are musculoskeletal disease, healthy ageing, cardiovascular health, clinical epidemiology, public health, and complex data analysis. I wonder what Monira does in her spare time. With over 83 publications in renowned journals such as BMJ, JAMA Cardiology, and Arthritis and Rheumatology, Dr. Hussain has made significant contributions to understanding the relationship between cardiovascular disease, or CVD, and musculoskeletal conditions. She is currently a senior research fellow at Monash University and a senior lecturer at the University of Melbourne. Monira is a wonderful presenter, researcher and health advocate, and we are extremely privileged that she has been able to join us tonight. Welcome, Monira.
Thank you very much, Helen. And it is a privilege for me to present in this session. And thank you very much for your warm introduction. So let me share my screen first. So before I start my talk, I would like to begin by acknowledging the traditional owners of the lands on which we are meeting today. I pay my respect to elders past and present and extend that respect to any Aboriginal and Torres Strait Islander peoples joining us for this session. So today I would like to take you through how arthritis, which is always come to us as severe debilitating joint pain or joint issue, can tell us a lot about our heart health. Here, what we will cover today. So first, we will look at how common arthritis and heart disease are. Then what makes someone more likely to develop them? We will explore what the two conditions have in common, why people with arthritis tend to have higher heart disease risk. And finally, what practical steps can help keep both joints and hearts healthy. So we will talk about both of them. Now, why this topic matters to me? Working with older adults, I often hear people say, I'm slowing down because of my joints. And that is true in most of the people who are today's attendees. And over the years, I have seen that this joint pain is one of the most common complaints as people age. And many of the same individuals also visit their doctors with heart related conditions, right? So the two conditions, arthritis and heart disease, they also, I have seen, that share some common features because these people are always less active. They carry a little bit extra weight, etc. So now what we actually see, and from my research, we have seen that people with arthritis had almost twofold risk of heart disease compared with the people without arthritis. Striking overlap because you can see that if there are two people and one had no issue, they have less likely chance to have this heart disease. But on the other hand, those people who are having the arthritis, they do have higher the chance of developing this heart disease. So what are the overlaps here? Both are chronic conditions. Both takes long term to develop, and they causes reduced quality of life, and they together make our everyday functioning much harder. So the encouraging part of this is there is a lot we can do once we understand the link between these two conditions. So before going to the link, let's look at this disease separately. So what do we mean by arthritis? Is it one disease? Actually, arthritis is not one disease, right? It is an umbrella term. When we say arthritis, we really talk about several different conditions. So what are the common conditions of them? I think here in this forum, a lot of you have heard about rheumatoid arthritis. It is an autoimmune disease. The body's immune system attacks the joints. It starts at younger age. So it is the disease when people are young, right? Young age arthritis. Then we have gout. So you have perhaps seen something like people talking their toes and the toe bed. It gets like swollen and there is some toffee. This is with high uric acid and the crystal deposition of uric acid in these joints. And that is so painful, people can't move. And then the most common form, and where my group and I work most, is osteoarthritis. This is the most common form of arthritis. So I will talk about osteoarthritis a little bit more in the next slide. But before going to that, I will just emphasize the fact that regardless of the type arthritis cause pain, stiffness, and loss of mobility. And it affects our everyday life, and it slows us down, and it just brings so much complexity that we feel like not moving, and the feeling of slowing down and feel like we are disabled, we can't do things as we wanted to do in our daily life. So now let's look at the most common arthritis. I will give you the most common arthritis, osteoarthritis, and its feature. So where does we have this arthritis to happen? So the most commonly affected joints are our knee joints, hip joints, hand joint, and shoulder joint. And you will find that now we are finding out there are some evidence that there are the intervertebral joints that gets affected with the problem as well. So let's look at what happens in osteoarthritic joint. So if you look at the left hand side, this is a healthy joint. So what do we have in healthy joint? So there are the bones, right? And then on top of the bone, there is a cap of cartilage. And the cartilage are there so that the joint can move freely. And to make this movement more congruent or more nice, you can see that between the joint there is a fluidy sort of thing, and this is synovial fluid. So when you have this fluid, it acts as a lubricant, and this joint moves very frequently. And then surrounding those things, we have the muscles, because muscle gives joint the support, right? So these are the normal structure of most of our joints. Now, what happens? What are the changes that happen with arthritic joint? First of all, in the right, we have this disease joint, and you can see that the cartilage cap that has degraded. So the cartilage thinning is there. And then the gap between the two bones has reduced. So there is the bone on bone, and when this bone has the friction, you start to get the pain. So what is the compensatory mechanism? Because body wants to, when we have the wear and tear, it wants to repair. So the bone tries to grow, but the formation of bone is not good. So you will see or hear that a lot of time doctors say that we have bone spurs in the joint or the osteophytes, and that is when it gets more and more worse. Also, with this fluid, it changes, and the fluid that is covered by the membrane, that has also inflammation. So this actually worsens our condition. And also in the supporting muscle here, you can see there is the weakness or atrophy of the muscle. And when we look at the cross-sectional area in our MRI, we can see that not the muscle shrink is there, but inside the muscle there are the fats, right? So in a nutshell, in a healthy joint, you will find that there are lots of good things happening, but in a diseased joint, the bone on bone there, bone friction there, and that is making painful joint. So now let's think about that how common arthritis is. So roughly 1 in 5 people gets any form of arthritis. But if you look at the graph at your right hand side, you will see that there are the age breakdowns, and we can see that arthritis becomes more common as people ages, right? So you will see that under the age of 25, here is the bracket where 25 to 34. But if you go just in the left hand side of that, that is under 25, very few people with arthritis, maybe 1%. But when people reach at their 45, so from this point on, you can see that there is a rise of the numbers of disease. So the numbers are climbing. And if you look at after 64, at the 65 age range or 75 or over, you will find that 2:1. So every 2 people who are more than 70 years of age, ask them that, do you have pain in your joint? Do you have arthritis? They will perhaps say yes. So that is how common the disease is. Now, for the treatment of the disease, we have a lot of health expenditure as well. In 2021, the expenditure, according to our Australian Health Institution data, that it was 5 billion Australian dollars. And this is just for joint replacement or the treatment that is listed in our MBS and PBS. That means apart from this cost, there are other costs which are hidden and not listed here. So you can understand that how much economic burden this disease poses to our health system as well. Now let's look at the risk factors. And Helen was mentioning that we talk about age. Yes, age is one of the biggest risk factor. It is a risk factor for every disease, right? So with age, our joint naturally wear over time, and this wear and tear causes osteoarthritis. Now, sex also plays a role because you will see that women are more likely to have osteoarthritis and other arthritis. But there are several reasons for that. That is a discussion for another topic, or perhaps we can address this in our question answer session. Now, obesity adds extra weight on our joint, and that causes mechanical loading. So, along with the age related wear and tear, when joints had to bear extra weight, then your joint degradation is much more faster. And this is especially the case for knees and hips. Also, obesity causes chronic low grade inflammation. Along with that, poor diet can contribute to inflammation as well and to obesity. So, what do I mean by poor diet? By poor diet, I mean that for convenience of our life, we sometimes like to take the canned food, go to the fast food, don't think that what we are eating, we just eat whatever we are getting, and especially when we are very busy. So this poor diet actually invites all these inflammation, obesity, etc. Again, being physically inactive makes the muscle weaker. So your support that I showed in the previous slide for osteoarthritic joint gets weaker. Not only that, physical inactivity increases the risk of getting more weight or extra fat in our body. So there are some interlinked factors there. These factors actually don't work in silo, rather they are very much interlinked. Now let's look at heart disease. So heart disease is the #1 cause of death in Australia and also all over the world. Now let's look at mainly in Australia. So more than 4 million Australians live with some sort of heart disease, and every 12 minutes, one Australian dies from it. So can you imagine in 1 hour, 5 people dies from heart disease? So it's a very big issue for our health. And the heart disease also had a major economic cost. So heart disease actually cost about our health system over more than $12 billion every year. And this is second highest cost after cancer. So it is very, very expensive. And again, when we are counting this expense, a lot of out of pocket costs are just hidden. So let's check what happens or how we have the heart attack. So here there is a big heart, and this is a pathological heart. We can see that there are the dead heart muscle, but how it happens. So if we look at the cross section of the area, so this is a small artery that supplies this area of the hearts, right? So here the yellow bit you can see that is plaque formation. So when people are obese, they don't have the proper diet, we start to get this sort of plaques. Now, once we have this plaque, then there you can see the narrowing of the artery, but still heart gets the blood supply. Then someday, because it is so slow, and at that time when you have this plaque, you don't have any symptoms. So symptoms are getting unnoticed. But then suddenly at one time point, the plaque ruptures. So when we have cut on our hand or any of the muscle, what happens? The blood comes out and then we have the scab formation, right? Because that is the healing process. So when these plaque ruptures, there are the blood that comes here and they form a clot. But this artery is so narrow that when we have this clot, the artery is blocked. So when the artery is blocked, the area it was supplied by the muscle starts to die. Now, if you are lucky enough, you will have angina. So angina means the chest pain. So for chest pain, you go to the doctor, right? But if you are not lucky enough, you can have a major heart attack that will again take you to the hospital. But sometimes the heart attack is so massive that people die. It is even not people can be taken to the hospital because before that they die from the disease. Now, what are the risk factors of heart disease? So for heart disease, we always talk like traditional risk factors and then the unconventional or non-traditional risk factors. So in this slide, I am showing you only the traditional risk factors for heart disease. And many of these risk factors are very much familiar to you. So what are these risk factors? I think high blood pressure, you have learned about it many times. We all know that if we do have high blood pressure and if we do not control it, then we have the risk of heart disease. Now here also we have a term called dyslipidemia. Now this is two conditions and this is related with our blood cholesterol. So what happens? We have heard about the LDL. LDL is the bad cholesterol. So when we have the bad cholesterol in high amount, this is dyslipidemia. When we have HDL low amount, HDL is often called the good cholesterol. And when this good cholesterol is in low amount, then we have dyslipidemia as well. So either having bad cholesterol in high amount or good cholesterol in low amount or both together is called dyslipidemia, and which are risk factors of heart disease. And we know that we are having statins for all these conditions. Now also diabetes. People with diabetes do have higher risk of heart disease, similarly obesity. Now let's look at what are the other risk factors. So in the other risk factor, we figured out that one of the major risk factor is being physically inactive because it reduces the heart fitness and also it increases obesity. Again, poor diet, because we have mentioned at the time of this risk factor when we were describing in arthritis that poor diet increases inflammation. It also raise the bad cholesterol and decrease the good cholesterol level. Similarly, it also increases our obesity. Now, stress also matters because when people have long-term stress for a very long duration, it raises the blood pressure and affect our immune system. And then finally, hormonal changes. You will see that there are many research that has shown that women, especially after their menopause, they have these hormonal changes and they have higher heart diseases. Now, if we look at this slide, I have tried to point out that from those two slides, what are the shared risk factor we found between arthritis and heart disease. Actually, we found that both the diseases are strongly influenced by the lifestyle factors and biological changes. Things like physical inactivity, obesity, chronic low-grade inflammation, poor diet, hormonal change, etc. That means these are the shared risk factor of both these diseases. Now, however, apart from obesity, here you cannot see the other traditional risk factor. Like, where is the diabetes? Where is the hypertension or high blood pressure here? But as I have mentioned, remember that all the non-conventional risk factors actually work through increasing the traditional risk factor, because we were talking that when you have poor diet, you have more inflammation, you have more obesity, the same with physical inactivity, etc. But still, science always go with proof. It want to see that whether it happens or not. So our question was that, are the traditional risk factors of heart disease also common in people with arthritis? So this is the study we have done, and this was done using the National Health Survey of Australia. We took a group of people who had been included in the health survey, and we wanted to see that if they do have arthritis, whether they have had more chance of having all the traditional risk factors of heart disease. So I'm not going to take you through this table because it looks clunky, but I have summarized it in the next slide. So what we have found that people with arthritis, they are 80% more likely to have high blood pressure. They are also twice as likely to have unhealthy cholesterol level. That means too much of the bad cholesterol and not enough of the good cholesterol, or either one. And they are around 60% more likely to have diabetes. And then they are about 75% more likely to be overweight and obese. However, here we are seeing that if you have osteoarthritis, then your risk of heart disease increases. You also do have higher amount of all those traditional risk factor. But actually, this relationship that we are seeing here is not that simple, because the reverse is also true. So we have found that when you have all these risk factors of heart disease and you have arthritis, and those who do have all these on top of their arthritis, they also have deterioration of their arthritis more. So if you have arthritis but don't have any of them, or if you have one of them or two of them, but if someone do have arthritis and all of them or maybe more of them, then they do have rapid progression of their arthritis to the joint failure, because you will know that especially osteoarthritis, it doesn't have any disease modifying drug, and having all these things actually leads them to have the ultimate stage where you need to treat your joint with joint replacement unless otherwise you can't move. Also, what happens when we do have arthritis? So for many people living with arthritis, pain relief is essential part of daily life, because arthritis causes pain, right? But some medications we use for pain relief or inflammation can also affect our heart health, especially when you use them for longer period and in higher doses. Now, of them, some of them are very harmful. So for example, we talk about the NSAIDs, and NSAIDs means ibuprofen like drug. Now, ibuprofen is over the counter drug, right? And like when we have pain and we can go to any of the pharmacies and can get the drug, we used to get the drug because we want to have painless life, right? And that is what we all deserve. But when we are taking these ibuprofen regular basis for a long time, then we are actually posing risk to our heart health. Similarly, when we have flare up of pain, say for example back pain, or in the arthritic joint, the joint pain, we are sort of advised to take corticosteroids. But the corticosteroids again increases the, because they do hormonal imbalance, so they increase the risk of obesity. You will see that when you take steroids, within few days you get or gain weight. And also if you are diabetic, then you are also given insulin because it increases the blood sugar as well. And by doing all these things, it poses a lot of harm in your heart health. Similarly, opiates or narcotics used for pain relief, but having them again for a long time, it increases dependency and also affects our heart health. The drug modifying agent, these are disease modifying drugs or disease modifying agents, these are most important for rheumatoid arthritis treatment. So when you have flare up, you are prescribed these agents, and having them again increases, and also for a long time increases the risk of heart disease. So what you can see that when pain medication is very important, but prolonged use of them actually poses risk to our heart health. So we need to actually think of that how we can use the minimal amount, and I will take you through that after a couple of slides. But before going to that, let's recap. So if we have arthritis, then having traditional risk factor is common, and also having this traditional risk factor worsen our arthritis. If we have arthritis, then we do have the other risk factors like low-grade inflammation, poor diet, physical inactivity, hormone levels very much changed, and that is also a risk factor. And also for pain relief, we use the pain medication. And all of them actually affects our heart health in a bad way. Now, people often feel well until a serious event occurs. Like, as I have mentioned, that as long as you don't have chest pain for heart disease, you don't usually go to your doctor because you don't know that you have all those risk factors inside you. However, the earlier we act by staying active, eating well, and checking our heart health, the more we can prevent our serious consequences or serious outcome. Because for heart problems, especially for the traditional risk factor, there are so many good medications. And if we use those medication, do some lifestyle changes, that will actually give us a sort of better heart health. Now, arthritis symptoms make people see their doctor because it is painful. We can't live with pain, and it is so painful that we go to our doctors. But then at that time, the heart disease risk factors like the high blood pressure or cholesterol can go unnoticed, but not necessarily every time. So what you can do when you are going to your doctor for your pain relief and pain medication, it is your natural opportunity. If your doctor do not give you the test for blood sugar or the blood cholesterol or the check your blood pressure, you can ask them that, hey, I have sore joints, but along with that, can I have another general checkup for all these things, because I want to know how my heart health is going, because that will protect your heart conditions. Now, apart from that, what are the general principles we can have to keep our joints and heart both healthy? So, this is the guideline of exercise from the American Heart Association, and it is also with our up to date. So what is said? Move regularly, right? So even when you have sort of osteoarthritis or pain, and that is one of the best thing I like about the Musculoskeletal Health Australia, because they are campaigning for the world biggest sit program. So even when you are sitting, you need to do exercise. So what about the American Heart Association or any association? So they say that you need to keep moving. You need to keep your exercise. And as exercise, ideal exercise, they suggest that you have to have 6,000 to 8,000 steps per day. You can do water-based exercise like swimming. If you do that, you need to do 2 to 3 times each week, and each session can be 30 to 45 minutes. Then you can do cycling 30 minutes per day. And then you can do strength training or stretching exercise like Tai Chi, yoga, Pilates, etc. But then people with arthritis, they would say that, hey, I have pain, I can't move, and if I want to do that bit, we will have an accident or a fall. And at this age also, like looking at osteoporosis is very important, because if you have fall, then you might have a fracture, which is a very severe condition, life-threatening condition. So for people who do have arthritis, the motto is move, but move wisely, right? So the amount of exercise you can do will vary from day to day, but it's okay. The key is that finding what actually your joints can tolerate, and do it regularly. Even small effort can make difference to pain and the strength and your heart health. So even if you can find that today I can do 5 minutes, do 5 minutes. Keep doing 5 minutes. You know pain fluctuates, and when you have a bad day, do whatever you can. In a good day, do as much as you can. So that will be the moving sort of motto for us. Now, also eat well. So, a balanced diet is good for your heart health. So, what do I mean by eat well? Remove all the canned food or preserved food from your diet. Try to add as much vegetables, as much fruits as you can. Reduce the sugary drink. Try to use or eat unsaturated fat, not the saturated one. So where is the unsaturated fat? You can eat the lean meat. Increase the protein consumption. And when you say oil, oil is bad. So if you can cut down the amount of oil, try to cut down. Yes, you can see, but different oil has different sort of effect. How about olive oil? I eat olive oil all the time. I use olive oil for cooking. Olive oil is better than other oil, but again, oil is oil. So try to think about it. Also, keeping joints and heart healthy means that you check your heart health. So when you are going to your doctor with your joint pain, ask your doctor to check the blood pressure, the cholesterol, blood sugar, etc. And most importantly, work with your healthcare team, because pain management, as I have shown you, that pain medication are also bad for your heart health. So work with your physiotherapist, work with your nutritionist, and work with your physician mainly to find out that what sort and what is the minimal duration of drug that will help you, because you need to control your pain. You can't live with pain. Similarly, you can't make it sort of in an amount that it is harmful for your heart. So there is the balance, and for this balance, you have the healthcare team, and they will help you to keep things in the right balance. So at the end, I would like to think about it, and the message I would like to leave you with is simple: that joint pain can be seen and felt. However, the heart risks cannot be. by recognizing their connection, we have an opportunity for early prevention. Every small step, every walk, every check, every healthy choice you make helps you protect not just your joint movement but also your heart health. So please try to change your lifestyle, try to adapt healthy lifestyle. It's not easy, you can't do it in one day, it takes time, but with time it will happen. So thank you all, and now I'm very happy to take some questions what you have. Thanks.
Thank you so much, Monira. That was fantastic and really, as I said in the introduction, I think the narrative that has been created is that, musculoskeletal disease, arthritis, they're not that serious. They're things you live with. Okay, they come with pain, but actually they are really serious, and the impacts they can have, as you've just shown, on life-threatening conditions like cardiovascular disease is so significant. And I think that's the narrative that we have to make sure everyone is aware of. And I'm really interested, obviously, those risk factors, and we'll touch on the medication side of things in a little bit. But those risk factors, as you were saying, the lack of movement, the lack of physical activity, the issues around weight, so being overweight or obese. When it comes to movement, we had a presentation by Kim Bennell, Professor Kim Bennell, last week around movement and physical activity and arthritis. What I'm interested in from your perspective is, we often get told in these sorts of situations where we've been diagnosed with a life-altering and lifelong condition that, well, you've got to get moving and you've got to lose weight. And for a lot of people, because of the pain, that's a really hard thing to, A, get your mind around, and B, find the right information that's going to help you do that. So I'm curious, from your research and from your knowledge, what is a good level of physical activity for people with arthritis, particularly in the beginning when you're first diagnosed and you're getting your head around everything?
So some of my research, and actually this is the area where I'm working on, that whether when we talk about that, well, you need to exercise, you need to lose weight, we get very scared because, like, well, I have painful joint, I can't move. How do I exercise and then lose weight? And weight loss is such a big issue because with a small amount of exercise, you can't lose weight, right? You need a massive chunk of exercise. So one of my research, I was trying to see that if someone from the childhood stick with the weight, same weight, because weight management is easier. Say, for example, if I say that I want to manage my weight where I am instead of losing what I have, like if someone say, okay, don't gain weight, but stay in the same level, and don't try to think of losing 5 kilo, then it is mentally sound and easy to achieve as well. Because then you think of that, today I'm going to party. I don't mind that people party and eat some food. But the thing is, like the next day, you can think of, okay, yesterday I had good amount of food. How about today? I do a less amount of food. When you have your pain, and pain is very much fluctuates, because you will ask the arthritis patient, what we have seen, that someday they do have a good day, but someday they do have very worse pain. But when even you have worse pain, like I think you know that how we encourage now people, even you are sitting, try to do something, try to move, try to do exercise. Even if you can do 5 minutes, do 5 minutes. Give a break. In the afternoon, do again 5 minutes. So make it a regular habit. You feel good, because when you start exercising, start moving, you will see that you can increase it step by step. So do it, but you don't have to do it today. I am saying that yes, for your heart health, 6,000 to 8,000 step is good. But a person who can't move actually 1,000 step, I shouldn't say them that. Rather, I should say them, okay, try to do 500 steps, or you do 1,000. Okay, how about doing 1,500, right? And after 1 month, I can check with you that whether you can do 1,500 or not. If you can, let's aim for 2,000, right? So it should be mixed up with your lifestyle, because these are the risk factors, these are the disease. They goes along with your life. It is chronic condition, and the lifestyle is in 1 day or 2 day for a chronic condition like this is not feasible or possible. So think.
And I think you make a really good point there, Monira, is I think what happens is when you're talking about physical activity, a lot of our minds automatically go to that structured, I've got to go to the gym, I've got to get up and I've got to walk 5 kilometers. Whereas if you think about it as about being perhaps less sedentary, so rather than sitting all day, thinking, as you said, okay, I could get up and walk to the letterbox, or I could get up and maybe just walk downstairs and then come back up and as you said, slowly build that up, and building that movement and physical activity into your daily life, because these conditions are part of your daily life and you're not going to solve them by
Exactly.
going from nothing to walking 10,000 steps a day. And in most cases, that's not possible.
Exactly. And I actually advise to match it up with our daily activities. Say, for example, when I work at Uni Melbourne. So when is my lunch time? I do my lunch and I feel like I will not have lunch from downstairs. I will just go to the student pavilion. I work near the Royal Melbourne Hospital campus. So that is a 1,000 step walk. If I don't prefer doing that and think of picking my lunch from downstairs, then I'm just with that. And after coming home, I will feel like, oh, I need to go to gym, have time, or I have family issues, etc. And again, when I go to Alfred, I can park my car just down to Alfred, but I park it to Chapel Street somewhere and walk down, because I match it with my daily life. Because if I walk down to my work, I have to walk down to get to the car. And that is how I'm doing. And I feel I advise the same, my friends and colleagues. And here also the same for our participants, because match it with your daily life. You will not feel the pressure that you have to do it in a certain amount of time or with a schedule or something.
Exactly. And Lauren just made a comment in the chat saying, if you make it functional, part of your daily life, then it doesn't become a chore. It literally just becomes part of your daily habits. And it's things like, you know, I know we're talking about nutrition and diet as well, but it's those little things like, okay, you shout yourself a coffee every morning, rather than driving to a coffee shop on your way to work. Find a coffee shop that's in walking distance and walk and get your coffee. It's those sort of functional aspects of building it in that obviously all build up and help over time. And you know, as you said earlier, where things like weight bearing exercise, particularly if you're in an acute pain episode, are not possible, there are other ways. And as you rightly pointed out, chair-based exercise is a way to keep yourself moving, because
Exactly.
we know that movement is so important. One question that was raised is, you mentioned gender earlier on in relation to cardiovascular disease. Is the prevalence of it greater in one gender than the other, or is it fairly across the board?
So actually, if you look at, so cardiovascular disease starts affecting us from middle age, right? And as we age. So if I think that the age rate is 40 to 50, and what is the rate of cardiovascular disease, to whom it is more common? More common in males, not in females. But when female do have their menopause, so after 50, they have their cardiovascular disease more, because at that time there are the hormonal factors, like for menopause, after menopause actually the estrogen level drops down a lot. We can't do anything about it, but keeping exercising means that we have a better level of hormones. And then also, if it is a very big issue, like if you have hot flashes and other things, then you need to go to your doctor. Your doctor will find out that what is beneficial for you. But after menopause, the rate of heart disease is more in female than compared to the same age males.
And with that, if we then tie it to, say, one of the musculoskeletal diseases, whether we're talking osteoporosis
Right.
or osteoarthritis, so obviously that point of menopause has an impact on it can have an impact on bone health as well.
Well, yes, estrogens do have, and not only estrogen, there are several factors that affects, and you will see that any time in life, women do have more osteoarthritis than others. And the reasons are multiple, because like one of the fact for us arthritis is like the weight bearing, right? So female do get pregnant, and they have to, with the parity, we have seen that there is an association of osteoarthritis. But does that mean that we shouldn't have child? No, we should have to have that, but that is the fact. You can't do about anything. You can't do anything about it, as you can't do anything about the age. But then again, after you have your childbirth and during the pregnancy period, do that regular exercise, do that regular chores which need some exercise, keep your weight managed. And if you do have other pregnancy related conditions, treat them. So ultimately, it is the choice of better lifestyle that will make your joint better as well. But yes, the several factors here, the hormonal factors, the reproductive factors, and then sometimes the contraceptions that we need to go through, all those do have effect on our joint and bone. And you will see that women do have musculoskeletal conditions more than the male counterparts. And you can't do about anything, but still you can be better by choosing better lifestyle.
I just before we start to wrap up, Monira, I just want to touch on when you were discussing the medications that are used for musculoskeletal disease in particular, and the interplay of those medications on cardiovascular disease. And I suppose that's a little bit concerning, particularly for people living with musculoskeletal disease, because you're treating one condition, but you
By the
obviously have.
expense of other.
Exactly. So how do one of the things we are very focused on as an organization is empowering the consumer, the person living with these conditions, to make informed decisions based on the evidence, based on clinical research. So what can help people make those decisions around, okay, from a rheumatological perspective, I've been told I need to take this medication, but the possible side effects are this, and this. How do you, as a researcher and a clinician, help people weigh up those differing issues that they have to navigate?
So first of all, when we go to our physician, they give us medications, right? Also, they give us some life stresses. But a lot of time, myself including, we feel like medication will change everything. So we try to follow the medication religiously. But the lifestyle, yes, we try to improve, but not like that. So what I suggest that from first of all or at the beginning, if we start doing both with the similar sort of importance, so for example, when we are given the disease modifying drug, we are also suggested that you do a little bit of exercise, or the same with corticosteroids. We are given that and we are said that, okay, do it. And after 15 days, we will check that how condition is doing, and then we will just adjust the doses. So if we just rely on the medication, our improvement will not be as much as we follow both. And then the drug will keep going longer. Feel like that, well, exercise is being very hard, then ask your physician that can I have support from a physiotherapist as well, because it's a teamwork, your pain management. And then when they will see that your disease has actually reduced or be limited, then they will take out the medication. So it is again you, if you are motivated, yes, I will just go through. I have the pain, I have to deal with, but also I have to make better choices, and I have to give my treating team the opportunity to reduce the medication, then you can do it. But if you just want to have only medication, yes, medication will be prolonged, and that has consequences. So it is the balance, like how you will make your choices.
Look, I think that's a fantastic point to end this evening's webinar on. We've gotten some really great comments about how informative and practical the webinar was, Monira. So it has been an absolutely incredible presentation. And I really want to take this opportunity to thank you for what is an informative and insightful dive into a topic that we should all really take seriously, because it is serious. Before we finish this evening, I have a few things to ask of everyone watching. How do I put this? Sit happens when you're trying to achieve a world record, and that's exactly what I need from you. I need you to register, sit and get moving with Musculoskeletal Health Australia on Sunday, the 26th of October. Maybe some of your students will come along, Monira, for the world's biggest sit-in. This is our attempt at breaking the world record for the largest 30-minute chair-based exercise workout ever held, and we need you. And going back to some of what Monira said, there will be variations of the workout, so please don't be worried. There will be something that everyone can do to participate and get their name in the record books. So there's two ways you can do this. You can join us in person at the Ripponlea Estate in Melbourne, or if you're anywhere else in Australia or the world, you can join us virtually via Zoom for the workout. At the in-person event, you can meet some of our amazing ambassadors, Luke Hines, who is going to be taking the workout, and our incredible MAM ambassador, Gerald Quigley, who will be delivering our 2025 Coadlo lecture next Tuesday night. His topic for his oration is Movement is Medicine, and that gets back to exactly what Monira has been saying to us tonight. So everyone, please join us on Sunday, the 26th of October. That's this Sunday. Gates open at 9:30 a.m. and the sit gets serious at 10:15. So get your name in the record books. You can head to wbsi.org.au and register your seat today, because if you're sitting, you should be moving. So I want to thank everyone who has joined us this evening. And once again, a huge thank you to Monira. It has been a phenomenal webinar to round out our consumer series for this year's Musculoskeletal Health Awareness Month. I'll see you all next week at the Coadlo lecture, as I said, being given by Gerald Quigley, and the amazing oration he will be giving is Movement is Medicine. So behalf of Musculoskeletal Health Australia, get sitting, get moving, and we'll see you next week. Thank you, Monira.
Thank you, Helen, and everybody.